All right, so let's go ahead and get rocking and rolling here. Thank you for joining us here. I'm going to actually pull up my chat box as well so I can see everybody. I see Jeff is in the crowd there too. Jeff, give me a shout out if you hear me. Make sure you're there, present. Nice. I don't see him yet there. All right. There we go. I see him. Nice. All right. It's nice to see my frequent flyers attending my workshops. It's good. I'd like to keep you guys on the straight and narrow. I always need a kick in the fanny sometimes, especially Jeff, that's for sure. So hello everybody. Once again, welcome to my low back pain and sciatica workshop. The main goal of the workshop today is to educate you, to give you some sense of how to manage your low back pain, your sciatica without unnecessary medications, injections, or surgeries. Hopefully by the end of the workshop today, you'll have a solid idea of what is going on with your back and hopefully an action plan of what to do about it. So especially during these crazy times of COVID, I mean, some people still don't want to go out. They're still a little leery about, going out to doctors, visits, let alone restaurants or PT. We're probably 99%, in person these days. We're not doing much telehealth anymore. We did initially, but we're back to pretty much, like I said, 99% in person. So it's workshops or platforms like this, workshops and telehealth that allows us to reach out to our patients and to, spread the OrthoWell gospel to help as many people as we possibly can. So a quick introduction for those of you that don't know me. There's several people with us today that have joined us for the first time. A bunch of other, folks are frequent flyers as well. But I am Chris Dukarski. For those of you that don't know me, I am the owner of OrthoWell Physical Therapy as well as Walkwell Foot Orthotics. I've been a PT for about 30 years. Time certainly flies when you're having fun. We have clinics here at the Cummings Center. We've been here since 2008. We opened up our Newburyport practice in 2014, and it's been a good run. Give me a shout out on the chat box if you have foot orthotics or if I've made you foot orthotics. Just curious. This is not the platform or the workshop for foot orthotics, but some people do come to see me, for foot orthotics for low back pain. Some pretty interesting evidence out there too that orthotics can help low back pain. So it's not necessarily the only thing. It's one possible factor, and it's certainly something that we will look into if you come to see us. We'll do a whole biomechanical assessment to see if there's the influence of your foot mechanics on your spine. Because if you're overpronating, of course, you're rotating in, and there's a lot of internal rotation, could affect your ankle, your knee, your hip, your back. Some people even say the TMJ. So if there's any need for orthotics, please let me know. Looks like several people. Jody, Jeff, for sure. But that's enough about me and the biz. I want to hear from you guys. So a couple of people have already shared some info. I want you just in the chat box, put your first name, put what you think is wrong with your back, whether it be you have a herniated disc, if a doctor told you that, or if you have like spinal stenosis, or your back just cotton big and hurts, and maybe something that's like your worst thing that provokes your pain. The one thing that really brings on your pain, whether it be walking, whether it be sitting for 20 minutes at work, picking up your kid, whatever, just to give us, some sense of what we're dealing with here, because then we'll kind of direct some of our presentation today to what we see. I mean, of course, there are main causes of low back pain and sciatica that we'll get into, but I definitely want to hear from you. So definitely enter that into the chat box so we can see what's going on there. So just a little bit of housekeeping here. If you have any questions during the presentation, I have my lovely moderator, Tasha, present to field those questions. You want to give us a little shout out there, Tasha? I don't hear you. Can you hear Tasha? I can hear
everyone.
Oh, there we go. There we go. Ask her questions at will, for sure. She'll field those to the best of her ability, and we will do the best to elucidate upon that later in the workshop. We'll save the Q&A for the end of the presentation. I also included in the email a worksheet. So if you haven't downloaded that worksheet, please do, because the presentation kind of mirrors the worksheet. It's a great way to enhance the educational experience here, just to get as much out of it as you possibly can. And for those of you who stick around for the entire presentation, we have a special bonus for you. For those of you that can hold out, this will not be overly taxing for you. You're talking probably 45, 50 minutes, and we'll have a QA at the end. But if you make it to the end, we'll have a special bonus for you. We'll talk about. So it's something that can really help your low back pain and can sometimes help it pretty quickly. So last thing, I want you to try to be as engaged as possible for this. You know, it can be pretty distracting at home. So let's make sure we keep you involved in the process here. So this is a screen I probably should have been on for my initial, what we had just gone through. So let's kind of work our way through here. So first question. So same thing, low back pain or sciatica within the past 30 days. I want to know if you do or whether you do not. So some of you entered some info about your histories here, some bruising, sciatica nerve pain, low back pain, yeah, undisciplined. I wonder who that is. At least we can be brutally honest here with each other for sure. Degenerative disc disease, disorder for sure. So yeah, give me a yes if you have back pain or sciatica. Just so I know that everybody here is in pain. Sometimes people listen for their loved ones or a friend or family member or something. So, because I want this to, like I said, I want this to be directed towards you guys. So, all right, yeah, definitely most all have pain for sure. So the three main causes of sciatica, all right? So number one, herniated discs, right? Sure you've heard of those. Number two, degenerative changes such as stenosis, degenerative disc disease or degenerative joint disease, and arthritis, all right? Kind of some big words here for arthritic changes, but we'll talk about that more later on. And then sacroiliac or SI joint dysfunction. So I think some of these things are on your worksheet as well to fill in. So I'm sure you guys have heard of the SI joint as well. Anybody here been told by anybody, whether it be a doctor or a chiropractor, that you have SI problems, SI joint problems? Give me a yes/SI. Yeah, so yep, Danielle, for sure. All right, so yeah, we'll talk more about that later on as well. So, all right, so what is the sciatic nerve? Of course, you probably have heard of it. Let's talk a little bit more about it. It's the longest nerve in your body, and it's actually composed of two nerves. The sciatic nerve travels down the leg into the foot, and when it is pinched, as the slide says, it can cause pain, tingling, and weakness in the leg, and sometimes heaviness in the leg. Let's kind of expand upon that a little bit. So nice little anatomy picture here. So it starts as 5 nerve roots up in your lumbar spine, and then it comes together, forms two main nerve trunks that go down, and then split someplace here behind the knee, and one actually curves around the outside of your leg. Actually, kind of an interesting story. Just really kind of a bizarre thing that happened this week with a patient. He went into the hospital, was in there for about 4 days, and shortly thereafter started developing weird sensations, numbness, tingling in his foot. And so went on for several weeks, and he got tested and realized that he developed drop foot. And the doctors attribute that to some sort of pressure that he was placing, maybe laying in the bed, on the outside of his knee. Okay, and right down here on the outside of your knee is the common peroneal nerve. Of course, it's around your fibular head, and for whatever reason, it got pinched and caused really significant sensation issues, as well as a palsy, a motor control issue with his muscles, the muscles that raise up his toes and raise up his ankle. So yeah, he got drop foot as a result of that. So where it can get pinched, of course, most oftentimes it'd be up in the lumbar spine, herniated disc, the degenerative changes we talked about, as well as there's something called, used to be called piriformis syndrome. Now it's called deep gluteal syndrome. Sometimes the sciatic nerve gets pinched along the piriformis muscle. Very infrequently, maybe 10 to 15% of people. It's very unlikely that there's an entrapment in that area, but some people do. So it's something we do screen for when we check people out. There's a lot of like neural tension testing, we call it, that we do. We do like a slump test where you bend forward, and I'm sure several of you have if you've been seen by a PT or by us before, it's something we do to sensitize the nervous system to see how irritable that nerve is. And sometimes by doing these tests, we can actually reproduce what we call your comparable sign, which is, yeah, Chris, that's my pain in my hip. That's my pain in my SI joint. When I am rolling out of bed in the morning, or when I go to, pick up my kid, out of the, out of the stroller. So, and we'll talk more about herniated discs going forward. So just a little bit more about how we came to specialize in low back pain. I certainly have my own histories. We talked about this a little bit in my shoulder pain workshop, but I grew up in Michigan, corn-fed and corn-bred. A lot of sports, big schools, big AAA schools, a lot of competition. I played baseball, basketball, tennis, ran track. So all that pounding, all those little issues, this is the stuff I'm sure many of you can I guess, what's the word I'm looking for, have in common with me, the fact that these things come back to haunt you in life. It's all the pounding, the injuries we've had in the past, depending on what we're doing during the day, can elicit symptoms. For me, it's the whole rotational thing. It's that combination of bending forward and twisting. And that's probably the worst thing for a disc. And I know I've had myself full-blown low back pain, full-blown sciatica down my leg. I've had, full-blown nerve pinching pain down my arm, so I, tell my patients I'm probably the most empathetic PT you could run across, because I probably have felt most of the things that you guys have felt. So for me, it's that golfing is huge, so a lot of rotational stresses with golf, so for me, for how infrequently I do golf, I'm just one of those people that I'll take one ibuprofen before I play, just to ward off any symptoms, coming forward. Last thing I want to feel is pain myself. But at least it's nice to know that we can self-treat as physical therapists, So as far as, other, you have your issues, you try to figure things out. For me, it's continuing education. There's a lot of self-study. I've worked with a lot of experts in the field, both doctors and really, really great physical therapists. And from that came my desire to share this information with my patients. So of course we have which many of you might have seen, the YouTube channel. We have the best 3 strategies for low back pain, for shoulder pain, for foot pain. I've written a book on low back pain and sciatica that you can get for free on the website, and it links you to my YouTube channel as well. As much as I can do to educate you, the better off you're going to be. I mean, that's, priority number 1 in our clinic. If I don't educate you, if I don't teach you to self-manage your symptoms, then I'm not doing my job. Right. And unfortunately, a lot of chiropractors don't do a lot with that. Some are better than others, but sometimes you go on, you get popped and clicked and maybe some e-stim and you're out the door. Our job is to get you independent and to get you as educated as possible. We do a lot of this, through our blog as well. So, and that you can certainly keep up with. You can get blog alerts, and, I'm sure many of you get our emails for trying to stay in contact with you. So a lot of this stuff goes out to enhance the educational experience. So one more thing when it comes to that whole idea of pain, when you have pain, the whole adage of when you go to your doctor, right? And you tell the doctor that, oh, your doctor hurts when I do this. And the doctor says, Chris, actually, I skipped a little bit more in my presentation. I'm going to have to go back sorry about that, people. Let me go back to this slide right here. Pretend that I didn't say what I had just said. We'll get back to that in a second. So what's the biggest mistake that low back sufferers, sciatica sufferers make? Of course, number 1, they do nothing. A lot of people tend to ignore their symptoms, okay? The back pain and sciatica rule, the longer you've had the pain, the longer it takes to go away. And that's true for back pain, it's true for shoulder pain, it's true for foot pain, pretty much right down the line. Give me a sense in the crowd here, how long your pain has been there. Just shoot me a little message on text here. 6 months, 6 weeks, 2 weeks, whether it be an acute problem, whether it be, a chronic issue. And Jeff, about a week or so. And it's good. I mean, it's good that you, the quicker you do something, the better off you're going to be. And like I said, the quicker we can get you better. So that's good. A couple people, 3 months. Yep. All right. So how do you know if you need physical therapy. All right. The biggest way that we discern that is if your symptoms are reproducible, then they're reducible, right? So what does it mean to be reproducible? If you can reproduce your pain through certain postures, through certain positions, through certain motions, it typically means that you can reduce your pain. If there's something you can do to bring on your pain, there's something you could probably do to take away your pain. 90% of the people that we see in physical therapy have this, what we call, really, it's mechanical low back pain. You can reproduce it doing this, but it gets better with that, right? The other 10%, we sometimes can struggle with. Hopefully you're not in that 10%. We don't know until we look at you. But some people need that injection. They need that MRI. They need a surgical consult. But most oftentimes, 90% of people get better. So how we ascertain whether you're one of those people in the 90% is what we call our functional movement assessment. It's our very unique thing that we do in physical therapy. It's very unique to what we do as physical therapists. It's how we ascertain what your functional diagnosis is. All right. So go ahead and give me a rate your pain from 0 to 10, 10 being the worst and 0 being nothing, for the movement that you described earlier that was the most provocative for your symptoms, right? If it's like sitting after 10 minutes, your pain's a 10 out of 10. Or getting up in the morning, when you first stand, or even when you roll in bed. Some people have a really hard time rolling in bed. And it could be an 8 out of 10, on the pain scale. So yeah, go ahead and put that in the chat box there. So what I was starting to say earlier is that you go to see your doctor and you tell your doctor you have pain. And the adage is, doctor hurts when I do this. The doctor says, well, don't do that, sort of thing, right? What the doctor should have said is that if your pain is reproducible, then it is reducible, which means you need to go to physical therapy, right? He would do you a much better service by sending you someplace that knows what they're doing, to like the OrthoWell low back pain and sciatica specialist. So a couple of people, 6 out of 10, yep, 2 years, yeah, 10 out of 10. Yikes. So that's good. There is an interesting study here, because when it comes down to what your doctor does for you, right? The doctor can give you medicine, right? They can give you special tests. And what the special tests tell us is they tell us something is structurally going on with your back. It doesn't tell us what functionally you can or you cannot do. And this study, kind of a geeky study here, but this is back in 1994. This is decades ago. You look at MRIs of healthy, pain-free backs, and they sent these to various doctors and radiologists and asked them to diagnose the imaging. 80% of the MRI interpretations came back with disc herniations and bulges, right? Sometimes 40% of the cases, more than one level, right? So what would say approximately 85% of low back pain cases have no definitive diagnosis, yet abnormalities such as bulges and degenerative changes are present. So what this basically says is just because you have structural changes, just because you have a herniated disc, just because the doctor said, oh my God, you have degenerative disc disease, you go home, you go online and start freaking out, what does that mean? Doesn't necessarily mean that's what's going to cause your pain. Mind you, in that 10% of people we mentioned, it can. And sometimes it progresses to a point where things are so narrowed that nerve has no place to go anymore. And you have to do a decompressive, foraminotomy to open up that space, which I've seen, many patients for, post-surgically. And they do very well with that. But you want to do as much as you can from a conservative standpoint to manage your symptoms going forward. So, very good. Okay. So, 3 ways to deal with pain. So let's give you kind of like a sequence of events of typically what happens, right? So you have pain, right? And something happens and you can't believe you did something so dumb, and you have an onset of a tweak or a sharp pain. And most oftentimes people will tend to ignore that pain. Be able to take some ice or some Advil, they use the ice for a little bit, and goes away. Then things start to happen, right? Things start to happen more often. Things are tweaking more. So the pain starts to impair your ability to put your socks on in the morning. You cough and you sneeze, and now you got this little zing down your butt to the back of your leg. And you wonder, well, what should I do? Well, most oftentimes you call the doctor, right? So you initially ignored it, then you got concerned about it. So you go to see your doctor. Doctor maybe tells you to increase your Advil, maybe gives you some oral steroids. And what does your doctor do? He tries to alter your pain, right? He's trying to change your pain. Instead of taking the next step from that, which we're going to get into here. He could order an MRI or an X-ray. He might send you to an orthopedic guy, which I'm sure this might be some of your histories here and your scenarios for how you got to me today. And then the ortho looks at your X-rays and goes, oh my gosh, look at this. You have degenerative disc disease. You have a herniated disc in these two places. Well, you might need an injection or you might need surgery, right? Same sort of thing. Your doctor is trying to alter your pain. So then you being a smart person, you go online, you find OrthoWell Physical Therapy, you do a workshop, and then boom, here you are. So here we are trying to, you're trying to handle your pain. You're trying to get a handle on it. You're trying to manage it. You're trying to get rid of it once and for all. And that's same sort of thing. That's what we do during our movement assessment, is to figure out how it is that we can help you going forward. Okay, so let's recap. First off, people ignore it. Obviously, you're not. You're doing something because you're here today. Your doctors want to alter it, and then hopefully we'll handle it and get rid of it once and for all. So any questions, about the things I'm sharing with you, please enter them into the chat box. Tasha will take those as we go along. So the most common causes of low back pain and sciatica. First one, herniated disc. So can a herniated disc cause pain? Most certainly. All right. So when it comes down to it, what's the origin of pain from the disc? You don't have to have just a bulging disc to cause pain. When you bend forward and you twist, that's a torque on your disc. It takes only 3 degrees or 2 to 3 degrees, or they say a 3 to 5% elongation of those collagen tissues on the outside of your disc to cause a disc sprain. And when you sprain that disc, the outer portion of your disc, we call it right over here, it's called the annulus fibrosus, has a lot of nerves on it. And once those nerves get torn or tweaked or irritated or chemically irritated, it can cause pain. Then over time, through repetitive stresses, through a lot of golf, through history of golfing and sports, which is my history, it can start to cause more of a bulging effect. So I'm sure you've heard the comparison to a water balloon, or a jelly-filled donut, right? If you have a donut or a water balloon, you squeeze one side of it. You squeeze here, where's the water going to go? It's going to get pushed this way, right? You push the other way, it'll push back the other way. Okay, in a confined state, the pressures are equal in all the different directions. That's I think Boyle's law or something. Remember your physics stuff and chemistry or whatever. But when things become weakened, when the back of your disc starts to become weakened, the back of your disc anatomically is weaker than the front part of your disc, right? So you're much more susceptible to that area thinning and the bulge forming. So when you bend forward, you pinch the front of your disc. That pushes the pressure backwards where the thinnest part of the disc is, hence where the bulge starts to form. And that's where the pressures can form, and the discs can form, and then it puts pressure on the nerve root that come out of your spine, and then pressure possibly in some cases on the spinal cord. So, which would not be a good thing. Okay, this is a slide we saw earlier, the herniated disc, how it affects one of the nerve roots, the 5 nerve roots that form the sciatic nerve. Which nerve root is affected will determine what part of your leg gets involved. That's why when you come to see us, we do nerve testing. We do the neural tension testing we mentioned earlier, reflex testing, sensation testing, muscle testing. My guy I mentioned earlier with that little nerve palsy thing had, clear L5S1 irritation. So he had some issues in his lumbar spine as well as issues peripherally. So he had kind of the double whammy right there. He had a history of herniated discs as well. So not a good situation. So then when it comes down to herniated discs, right, what are the motions that cause pain? Okay. So as we mentioned, as I bend forward, I put the pressure on the front, thereby the bulge moves backwards. So bending forward is going to cause more pain. So if you bend forward to get to brush your teeth, to rinse, a lot of people will bend over the whole time, right? And then you're in full flexion the whole time you're standing there, right? Bending forward, twisting, and sitting. A lot of prolonged sitting is really tough for people with herniated discs. Things that make herniated discs better are things like bending backwards, walking, and generalized motion. Discs don't like to be static. They don't like to be sedentary. Discs like to be moving. So that's why it's so hard in the morning for people with herniated discs, to get moving and to get about their day. And typically, herniated discs happen anywhere between the ages of 35 and 50. Okay, so 40 years or old or younger, but anywhere from 35 to 50 is pretty much the age range for herniated discs. So most common cause, again, any questions about that? Just put your info, your questions in there. Why don't you, we'll talk about this in a second here, but let's go on to arthritis and stenosis. So the next very common cause, you can see the picture right here, how degenerative changes can start to occur in that area where the nerves come out of your spine, your spinal cord. So this is the intervertebral foramen. That's where those nerve roots come out. They exit your spine, and that's exactly where they get pinched. So typically, degenerative changes occur in people who have more than 50 candles on their birthday cakes. All right, so over the age of 50, close to 90% of back pain is from degenerative causes. All right. So what is spinal stenosis? All right, so spinal stenosis is a narrowing of your spine, right? The lumen around that the spinal cord goes through, your spinal canal, right, can start to be compressed. And that can be compressed by these degenerative changes that occur here. Then spurring starts to form here. There's little spikes that start to stick out that can dig into your spinal cord. Let alone stenosis in this area right here, this little intervertebral foramen that we mentioned earlier. All right, you see, an X-ray, you can see how increased the curve is here, thereby a nice, spacing right through here, then next to nothing right through here. And of course, that can cause a lot of nerve entrapment, a lot of nerve irritation. Nerves don't tend to get really painful unless they become chemically irritated. So that's, of course, time, wears on, you start to continue to irritate, chemical irritation starts to occur, and then pain starts to kick in. Some people develop numbness and tingling before they get pain. Okay, and that's more from pressure versus a chemical irritation. Okay. So some of you might, if you're over the age of 50 and you've had stenosis, have this whole shopping cart sign. You feel much better when you're bent over something and walking on something, right? Or with something, I should say. So people with a walker, they go to the grocery store, they're leaning over the cart. It just feels better because by bending forward, what are you doing? By bending forward, you're opening up the spine from behind. When you bend backwards, you compress the spine, right? So not a very comfortable looking position right there. Hopefully, Jeff, you're not doing this as part of your yoga routine these days. So pain worse with standing, with walking, with bending backwards. Okay. If it's just arthritic, wear and tear sorts of things, sometimes walking makes it feel better because as we get older, we physiologically lose the ability to hold water in our joints, in our tissues. As you move, you actually stimulate the production of these substances that bind water in your joints. So movement, riding a bike, walking, knee to chest, side to side rotations in bed is good just to get things moving. But if there's a stenotic problem, you just don't do well with walking and standing because it's this constant load and constant compression as you bend backwards, right? You're compressing the space, you're causing more of the pinch. So you feel better sitting, you feel better bending forwards. So give me a sense, just based upon, one more to talk about, sorry. So sacroiliac joint pain. We don't see it a lot, honestly. Chiropractors love to say that you have SI joint pain. It's maybe occurs in 10 to 15, some studies, 10 to 20% of the cases. I tend not to see it a lot. For those of you that don't know about the SI joint, it's the articulation between your sacrum and your ilium bones over here. So the sacroiliac joints. So it tends to be a very stable joint. There's not a lot of motion. You're talking maybe 2 to 3 millimeters, 2 to less than 5 degrees of motion there. Sometimes you can have more motion in the pelvis, the third trimester of pregnancy. Obviously, for obvious reasons, things have to open up, let the baby go through the birth canal. So these joints tend to be looser. And that's, of course, a hormonally driven thing. But the thing that usually can cause an SI problem would be trauma. Like you're walking, you don't see a curb, and you fall and you land hard, and you have this hard impact force up through your pelvis. Or you fall off your bike and you extend your leg and you hit it really hard. Or car accident, same sort of thing. You go to brace yourself and you put your leg out, and all that trauma just pushes your pelvis right out. Because the SI joint is a force coupler. It dampens a lot of the load that comes up through your legs, right? So if the load's too great, as is the problem with most of orthopedic issues we treat here, the force is too great, you can't dampen it, you can't, your tissues aren't conditioned enough for it. Or if you're hypermobile, right, just have this hypermobile tendency genetically, or you're a former dancer or gymnast, or maybe you worked at the Cirque du Soleil as a contortionist or something. So you're very, very hypermobile. And sometimes these people and I've felt them, you can really move that joint and you can actually move them in, move them out. Okay. So they're much more susceptible to subluxations, we call. Okay. So typically pain for sitting long periods of time, pain localized right at that SI joint, hurts right at that joint where that guy's grabbing it, hurts right here, doc. All right. Sometimes the pain refers it to your groin or the side of your leg. And in a lot of cases too, when it comes down to hip pain, we have to ascertain when you come in to see us, is it low back? Is it lumbar? Is it SI? Is it hip? And we have special tests that we use to ascertain that. And because sometimes, just like the neck, like in my shoulder talk, we talk about this interplay of the neck, the first rib, the shoulder, the AC joint. All these things can factor in on what you feel for pain up in here. Just as in the low back, lumbar, hip, SI. But there are presentations that we typically hear when we ask questions that move us in a direction of a certain presentation. All right. So based upon that, I've given you a lot of info here. About some of the stuff you might have gotten online, you might have heard from a former PT or a doctor. Give me a sense of what you think that you have. Do you think you have a herniated disc? Do you think you just have a disc sprain? Right? Do you think you have degenerative disc disease, which I think somebody had mentioned earlier? Or do you think you have an SI problem? And that's based upon what we talked about. What causes an increase in your pain? What makes your pain feel better? Okay. So give me a sense of, in the chat box there, what you guys think is going on here. And the worksheet, I want you guys go through that. For those of you, hopefully you have the worksheet. And pretty much have gone through most of the information that's on that. So any questions, you need any more clarification on the worksheet, please send Tasha a question in the chat box there. So some sciatica stuff, some degenerative disc disease issues in the group here tonight. So, okay, good. So what does successful treatment look like when it comes to treating your low back pain or your sciatica? First off, it's identifying the problem. We just talked about that, this idea we have to perform our special testing, our specialized functional movement assessment to figure out what it is that you are presenting with, right? That's, priority number one. Okay, number two is this whole hands-on therapy. We do so much when it comes to what we do from a hands-on therapy standpoint, a manual therapy standpoint here in the clinic. Whether it be mobilization, whether it be manipulation, whether it be Graston, ART, cupping, there's so many things that can factor into your pain. Sometimes your muscles become a very strong secondary problem. Could be your spine is the original problem, and now your muscles are guarding, they're reactive. Your glutes are like, you got a big knot in your glute. Obviously, it's right next to your SI joint. It's right next to your back, right? So it can certainly start to guard and protect, and that's also stuff that we'll treat. You treat the spinal issues, and then you treat the the secondary muscle issues as well. Manual traction is a really common modality we use here for low back pain. Traction is a modality we use to cause a decompression. So if something's compressed in your spine and we can do something to take the pressure off of it, right, should make it feel better. So we do traction as a modality for treating the pain. Sometimes we put a harness around you and then pull. Some of you might have experienced that before. Or we use traction as a way of discerning through diagnosis whether traction can help, right? So if it hurts doing something and I go from behind you and I lift you up and the pain goes away, we know that something is getting compressed in your spine. That's a great way for us to ascertain whether traction could help you, all right? So when it comes to exercise, it's not just stretches that get people better. Yoga, some people love yoga. I do as well. I do my certain poses and I incorporate that into my routine, but stretching is not the only game in town when it comes to treating your symptoms. There's gold level evidence, level 1 evidence for core stability exercise being the best thing to treat low back pain and the best thing to prevent recurrence of low back pain. So that's something that has to be built into your program. If you're in that, and I'm one to talk when it comes to yoga. I did my yoga thing twice a week for pretty much all last year, kind of doing something different. It was kind of like my Friday night jam. I would go and tell my wife I'm going to yoga class at 5, and of course I'd, hey, it's convenient. The brewery is on the way home, so I stop by the brewery and have a beer afterwards, and shoot the with a friend or the bartender there. But I realized that by doing that, I was missing out on one strength session in the course of the week because I have limited time. I'm sure like a lot of you do, and I started actually experiencing more pain as a result, based on my history and the fact that I've got to stabilize, which I mentioned earlier. I really felt a deficit not having that second strength session. So I basically ditched the yoga, didn't ditch the brewery, of course. That'd be kind of silly. And have been much better for it. So, and when it comes down to treating, people from, this whole, paradigm of how we exercise, right? People come to see us because it hurts. You then move on to work on mobility, right? Then you work on stability, and then you work on loading the system, increasing the resistance to the system to optimize your functional recovery, leading to optimizing your performance, whether it be you getting back to running, back to powerlifting, back to playing tennis. That's pretty much the paradigm we go through. You don't want to stop when the pain's gone, because once the pain's gone, right, people, I'm fine, I can handle this on my own. 2 weeks later, boom, Chris, that could be what happened. Well, I can believe it because you stopped your exercises. You need to stabilize to prevent return of your symptoms. Okay. So, and we also have something here. It's a class 4 laser, and it's something kind of unique to our clinic. There's not a lot of clinics that have these. We demoed several and just had some awesome results. They're used by NFL teams. They're used by the NBA teams, Division I collegiate teams use these as well because they work, because they make their athletes better faster. You're paying, your quarterback, $20 million a year. You don't want him to be missing games. So what modalities could we use to help expedite that process? Laser actually started in the equine industry back in 2000. It was approved by the FDA in 2008. And I use it on my dog after his surgery as well. We've had just a ton of great results. I've got a whole web page where I describe laser. What laser does, laser stimulates through an infrared laser beam. It stimulates chemical reactions in the cells to jumpstart healing, decrease pain, and decrease inflammation. So it's certainly something we can include in your treatment. So good. All right. So what do we do next? All right. So let's kind of recap what we've done here. So obviously you all stated that you have low back pain or sciatica. You saw the ad for those of you that are new to OrthoWell and you new to my fast-paced talk as I'm sharing my OrthoWell gospel here. You registered for the workshop. You shared information. I shared information. You shared stuff. Some people said they had pain lifting their kid, pain in the morning, pain bending forward. Some people said pain with coughing and sneezing, which is a very common problem with herniated discs for sure. So you have low back pain, and I'm guessing that you want to do something about it, right? So you don't want to ignore your pain anymore. You don't want to have your doctor just simply alter your pain through medications, injections, or whatever. You want to finally start to handle your pain. So this is what I'm recommending for you. So COVID, of course, is still here. We can certainly see you in-person-wise. And that's usually the best way to go about doing this. You can certainly call us, 978-522-4199. You can go to orthowellpt.com/schedule, and you can enter your info. We'll get back to you ASAP. Michelle is actually on duty tonight. She might have a cocktail in her hand as she's answering the phone here. But she can take your phone call and get you the books with one of us. And as you're doing that, as you maybe are looking up the orthowellpt.com, this is what the landing page looks like. You could enter your name, email, phone number as well, just to give you a sense of, if you've never been to physical therapy, which in a lot of cases, this is what happens. People have never experienced it. They find us and they start to search around and realize that there's a lot of info on the website. So when you come to see your therapist, right, the first thing we're going to do is we're going to have you provide us a detailed history of your pain. As I mentioned, there's a lot of clues in your history that tell us whether you have a herniated disc, stenosis, SI joint. And based upon that, will lead us into a direction for the testing that we'll do going forward. The second thing is to do our special testing, to do our functional movement assessment to ascertain what it is that we think is going on. Of course, with telehealth, we can't, do as many things hands-on. We can certainly get a very 95%, accurate idea of what's going on just by having you demonstrate stuff, online and through video. It's stuff that we did back right after COVID started, and had some pretty good successes doing that. So based upon all of that, your subjective information, our objective testing, your therapist will give you a detailed history or a detailed explanation of what it is that's going on, and give you some sense of what a successful treatment will look like to get you better faster. And when you call us, you will certainly be seen by one of our therapists that specializes in low back pain and sciatica. So that's what's good about coming to our clinic, is that we all treat very much the same. We are all on the same page through what we call the OrthoWell system, for all the things that we provide from a manual therapy standpoint and from a differential diagnosis standpoint, trying to figure out what exactly it is that is causing your pain. Okay, so the next step is really up to you. It's, you go into orthowellpt.com/schedule, call Michelle. Like I said, she's on duty right now. So, and as I mentioned, for those of you that have made it the whole, oh man, look at that. It's pretty good timing too, 45 minutes. I guess I'm good to my word on that. It happens when you're a fast talker. So as a bonus, for those of you that have stuck around, looks like most people have, which is good. We're going to give you 2 free deep tissue laser therapy sessions. Go to the website and learn more about it so you don't get freaked out by laser. It can't hurt you. It can only help you. There's great evidence regarding laser, as I mentioned. So you can call Michelle, and you can, if you want to just start with that. People are just kind of testing the waters and not quite sure. They want to do PT. They want to talk to Michelle first and see if the insurance covers it, which most major health plans we take, right? And they should cover your PT except for a copay or whatever. But if you want to try the laser first, and you come in and talk to us, we can do a free screen as well to get a sense of what's going on with your back, and get a true sense of what's causing your sciatica. We can do that as well. So with that said, I'm gonna bring Tasha back in here and see if there's any unanswered questions that anybody has had, or anything I've got to expand upon. So what you got for me, Tosh? Got to unmute yourself.
So one question I see a lot of is sleeping position.
Yep.
And what kind of things you can start doing right away to help relieve your pain over time. So not staying stationary. What can you do? Like walking around? What's the best thing to start with?
Well, of course, the most obvious thing is to set your alarm every 2 hours and get up and move. You know what? That seems like common sense to me. Of course not. So first off, in primary, what kind of mattress do you have? Right. That's the biggest thing. If you are, say, for example, you have stenosis on your left side, and you lay on a mattress that's really soft, and you like to lay in, what's the position in, I'm drawing a blank here. When you lay on your side with your knees bent up.
Fetal.
Fetal position. Thank you, Tasha. That's why we have you around, for your smarts, your wicked Canadian smarts. And you lay on your right side, right? What happens? You lay on your right side and you sink in the mattress. And then your leg crosses over as you're sleeping, because you don't know what you're doing when you're sleeping. You're just moving. And then you rotate your spine. So basically, you're laying in a soft mattress. You're bending to the left. You're rotating to the right. And what do? To that spot that's already compressed, you're doing this even more. And hence why you wake up with sharp pain, or why you can't, get comfortable sleeping at night. So then, of course, mattress is a huge issue. I tell people, try a different mattress. Try your kid's mattress, or pull out the camping mattress that's much firmer and pump it up. People that have the whole Sleep Number mattresses can really, much more beneficial. They have more options for firmness versus softness, and see if that helps. And you'll ascertain whether it does and whether it doesn't, whether you need a mattress or you need to sleep maybe on your camping mattress until your symptoms calm down, right? So really you're trying to find the position of comfort. If you can't sleep and rest and heal and restore at night, it's going to be hard for you to feel good and to heal going forward. So in most cases, people feel the best laying in their back, right? With maybe a pillow underneath their knees to create a little bit of flexion in their spine. And that, of course, would be definitely the case with a stenosis patient or somebody who has got degenerative problems where we have that narrowing effect, right? Maybe not so great for a herniated disc. Some people with herniated disc feel better on their stomach. It might hurt initially to lay in their stomach, but then they're kind of in that extended position to kind of push that bulge back in. And that's, in some cases, one of our key exercises for treating a herniated disc are press-ups. We try to push up and down. It's like cobra in yoga for the yoga people out there, to push that bulge back in. And that's in my best 3 strategies on the YouTube channel. We talk about the best exercises for sciatica, for herniated discs, what have you. So yeah, so that's pretty much, I think it's pretty good for the sleeping position. So anything else?
How do you feel about back braces?
Yeah, that's a good question too. So a lot of doctors feel as though you shouldn't wear back braces because it'll make you weaker. Now that's, of course, if you didn't learn how to do exercises, that might be the case. And hopefully your doctor, once they find out if you're, if you have pain, if it's reproducible, then it's reducible, they'll send you to physical therapy. And then we'll tell you that braces help to augment the effect of your muscles, right? If you're really irritated and you need to function, need to go to work, need to brush your teeth, you need to take care of your kids, need to get in your car and drive to work. If I can provide another, modality to you, another intervention that'll help to make you feel better, then why not use it, right? Back braces can really help to stabilize your spine. There's even some data that says you can dampen the load and the pressures in your discs. I think I read way back when by like up to 20%, but we'd have to go back and see if that's really a valid study. But by having that brace around you, it just gives you a sense of stability. I tell people if it hurts at night, wear the brace at night, right? That can really help our neck patients, can help our back patients. And then we teach you core stability exercises. So as you're in that brace, you're bracing your core properly, you're engaging the right muscles. So that brace is only going to augment the effect of your muscles to help better stabilize, to better decrease the load to your spine, to encourage healing faster. So hopefully that answers that. Anything more?
So, assuming someone has stenosis, does ice or heat help? And where should it be applied? On the lower back or on the leg where the symptoms are?
Yeah. Okay, that's good. So, well, it's not really going to help too much if it's a nerve root pinch in your lumbar spine to put the the heat of the ice on your leg, right? So when it comes down to can you directly treat the stenosis or the pinch, the arthritic problem with ice or the heat? Is it going to penetrate that far down? Well, probably not. You're talking ice can maybe penetrate a centimeter, heat maybe even a little less, so it's not really going to go down through all those muscles or all those layers of muscles down to that area. What it does is, what does ice do? Ice is great for numbing the area, right? So if you are sore, right, and you're sore in your back or even your leg, meaning you want just something to numb it, to take the edge off the pain, then icing, using Icy Hot, the gels, are basically all what we call counter irritants. You're trying to override the pain receptors. Whereas heat can bring in more circulation. Heat is more of a healing modality because you're trying to bring more fluids in. You're trying to foster healing. You're trying to push in the good. You're trying to push out the bad, right? Cold will shut things down. So more circulation won't get in because you're constricting the blood vessels. Whereas heat will dilate the blood vessels. And that's why after an ankle sprain, you don't necessarily want to put on heat. There is some interesting data that's telling you maybe you should, and use heat in combination with motion to open up vessels. And as you use motion, you're pushing the bad out and the good in, okay? Versus just putting the heat on statically without the motion could increase the swelling, right? So So I would typically say, and back to the old, way of approaching this, the first couple of days you're using cold, right, to try to downregulate the pain, decrease the swelling, help to, just take the edge off, and then transition to heat. And some people will alternate ice and then heat, ice and then heat. And there's nothing wrong with that either, because you're shutting down and opening up, shutting down and opening up. So it's really your call. And because it is more superficial, maybe you're more treating the muscle. You're treating more of the secondary problems that we talked about. You can certainly affect your glute muscle. You can certainly affect your lumbar paraspinal muscles or your QL muscle by putting heat or ice on them, okay? Because they're much more superficial. So you try it. If it works, great. If it doesn't, then come and see us. We'll give you another intervention going forward. So.
What about an at-home TENS machine?
So we tend to, it can't hurt anything to use TENS. Is there necessarily healing stimulus with TENS? There's really nothing that in our research that says so. It's kind of like the whole gate control theory of pain. You're stimulating nerves to override pain receptors at your spinal level, and over time that can help to, decrease the sensitivity of nerves. If you have one, sure, same sort of thing. It's a counter irritant. Use that in combination with ice or with cold, or ice or with heat. It certainly can't hurt. It's not something that we use in the clinic here. It's kind of a last resort thing. Well, nothing else has helped, so try some TENS, see if that helps you.
Where would they apply it, Chris?
You can put it right on the spot of pain. You can put it right on your low back. So, and typically you want to put it where the pain is. But same sort of thing to the point of putting ice on your sciatic leg, right? If you know that the problem's coming from your back, put it over your back, because more than likely it's a sciatic referral coming from some sort of pinch in your lumbar spine. To put like one on each side, you can cross the circuits, the electrodes, and put the wires, to crisscross, and that's usually fine. And if it helps, great.
What do you think would cause numbness in the leg above the knee? And is it possible for it to go away?
Well, any of the above, really. SI joint problems, lumbar stenosis, herniated discs. It's just a matter of figuring out what it is that's going on. And that's that whole functional movement assessment. The problem with, and this is on the worksheet, if you don't quite know what's going on with you, you could certainly experiment and try repeated flexions going forward, try repeated extensions going backwards, and hopefully you won't hurt yourself. It's a chance that you take by, self-treating without getting, professional guidance with this stuff. So it's tough to say. It's tough to say if the numbness in the upper leg is from one of the above without actually performing the tests. Because like I said, the nerve roots start in your back, and then they have this pattern, this distribution of what they innervate down the entire leg from the top all the way down. It's not just like one spot on the bottom of your leg. It's kind of like this channel, this course of sensation, dermatomal pattern, myotomal pattern, the sensation and the muscle patterns that these nerve roots follow. So yeah, can't be any more helpful than that. Sorry. Anything else?
That'll be it.
That'll be it. Awesome. Well, thank you all for attending. Looks like we're just below the hour, so that's great. It was great to share information with you today. Me and my team are certainly looking forward to helping you out and hopefully getting rid of your low back pain and your sciatica once and for all. So give us a buzz. Go to orthowellpt.com/schedule, as we mentioned. You can book your laser sessions for those of you that are still around. You guys are very welcome. For those that are saying thank you for attending, and hopefully we'll see you soon. So, okay, we'll see you.